Hello and welcome to another Rush Generations Health Education Lecture. Rush Generations and our staff is delighted to be your source of information, resources, and health programs that help maximize your well-being and good health as you age. Today is Wednesday, February 19th, and I'm Franco Sampataro. I'll be your moderator for today's lecture, Intimacy and Sexual Health. Before I present to you the wonderful speakers joining us today, I'd like to first thank Hannah Weinsman for helping with the production of this lecture, helping us manage the chat and other key aspects so that we can all have a great discussion about common sexual health concerns as we age, as well as ways to foster intimacy. As always, we're live streaming this lecture via our YouTube channel using the video platform Zoom, which allows us to host a good number of people who join us via phone. Thank you so much for joining us. And for those on YouTube, we ask that you please use the chat function to ask questions and or to add to the discussions throughout the lecture. We will make sure that your comments and questions make it to the presenter. And for those of you listening to the discussion via phone, you will have an opportunity to, at the end of the presentations, to unmute yourself and your audio so that you can ask your questions. We'd like to remind you that all the information offered here is for general informational purposes only, and to always seek professional advice for situations specific to you and your needs. So without further ado, I'd like to introduce our lecturers for today. Our first lecturer today will be Dr. Lawrence Levine. He is a graduate of University of Colorado School of Medicine and completed 2 years of general surgical residency training at Tufts New England Medical Center in Boston, followed by a year in Paris at the American Hospital, where he was chief resident of medicine and surgery. He completed his urology training at the Harvard program in urology at Brigham and Women's Medical Center in Boston in 1987. He began as an assistant professor of urology in the Department of Surgery at the University of Chicago Medical Center. In 1992, he moved to Rush University Medical Center, where he remains a professor of urology and is in active clinical practice with Europartners Solaris Health. He established a fellowship in andrology and male genital reconstruction in 2017 at Rush, and his focus in practice in clinical research is in the field of men's health, including erectile dysfunction, Peyronie's disease, and urethral stricture, chronic scrotal content pain, hypogonadism, and male infertility. Our next presenter today will be Dawn Ravine. Dawn has a master's in public health from Columbia University with a focus on gender and sexuality health. She has spent the past 25 years in sexuality education with teens and tweens. Dawn is currently the manager of health education at Lurie Children's Hospital as part of the community programs and initiatives team in the Division of Adolescent Medicine. She loves yoga and swimming, all the TV, and listening to audiobooks and podcasts, and is desperately awaiting the re-emergence of beach season. Welcome you both, and without further ado, I'd like to hand it off to Dr. Levine.
All right. Well, thank you, Franco, for that nice introduction. So I'm Larry Levine. I'm a urologist here at Rush, been here for remarkably 32 plus years. And I've developed an interest in particular in men's sexual health that all began many years ago as a result of just seeing more and more men who were suffering with erectile problems, genital deformity problems. And gradually my practice emerged or became more focused in that area, as did my research. I'm delighted to be here again talking to Rush Generations about this problem. Intimacy for men and women too is certainly going to be both a psychodynamic process, what's in our head in terms of becoming aroused, but it also, of course, ends up having a physical component to it. So the physical aspects of intimacy that will allow intimacy are going to be being able to have an adequate, rigid penis for penetrative sex. Needless to say, there are many different ways of enjoying sexual activity, but if we're looking at the ability to have penetrative sex, it will require a rigid penis. And we'll talk about that first. The other aspect that is more what we might call a permissive process, meaning allowing erections to occur, will be pertaining to things around libido. And libido is the drive that we have to engage in sexual activity. And of course, both men and women experience libido. And interestingly, the primary hormone in both men and women is testosterone. Testosterone much higher in men than in women, but still a certain amount of testosterone is critical for a proper libido in the female patient or the female as well. So we'll talk a bit about the importance of testosterone as I finish up my presentation today. So let's start by talking about ED. Historically, I think we used to think about erectile dysfunction as being something, in our head. And certainly that's important because men who do have issues with erectile dysfunction can get psychologically distressed and anxious. And this can, of course, interfere with the ability to have satisfactory sexual activity. But I think we now recognize, as a result of research that's probably now 40 or 50 years old, that the majority of erectile dysfunction is or is physical or organic, and certainly may have, I would say, maybe always has a psychological component as well, but primarily may be a physical one. And that may be regardless of age, but certainly for men over the age of 40, about 50% of men will have some degree of erectile dysfunction, which, as the man gets older, is more likely to occur. And as we get older, more likely to be more severe. So maybe initially it might be, geez, I just can't get as rigid as I used to, or it's easy to obtain, but it's harder to maintain it. And then as it gets progressively worse, it may be just impossible to even obtain a satisfactory erection. And of course, these are the things that we would determine in a consultation. Studies have also shown that the majority of men who have organic or physical erectile dysfunction, it's usually a vascular problem, things which affect the tiny little blood vessels that we have in the penis. In fact, the penile arteries are some of the smallest ones in the body. There are two vessels, one on each side of the penis. We have two erectile bodies. Each one is supplied by a cavernosal artery, we call it, and that's about a 1 millimeter diameter artery, and that's 1/3 the size of a coronary artery, one that supports your heart. So a small vessel like that, a small amount of injury can have a substantial effect upon blood flow into the penis. So what are the things that will most likely result in erectile dysfunction? And I call them the erection busters, things which accelerate vascular aging. I like to say that we can thank our parents for how we age. That's sort of genetically coded, and we can't really slow the aging process, but we can accelerate it. And things which will accelerate aging will include diabetes, high blood pressure, elevated cholesterol, and probably one of the easiest ones to stop or to reverse would be tobacco, smoking. And in fact, in my practice, probably the number one most common singular reversible problem of ED would be smoking. And if we can get men to stop smoking, we can not only reverse potentially some of the effects in their penis, but also those things that affect coronary arteries, blood flow to the brain, kidneys, etc. So if you've got vascular disease in your penis, you got it everywhere. It's just that the penis may be one of the earliest ones to show that. And I like to refer to the penis to my male patients as the divining rod of vascular health. If you've got vascular disease in the penis, that's telling us that you might have vascular disease elsewhere. So in men who present, I would say with ED, the great majority of those men, particularly if they're over the age of 50, will have some type of vascular disorder. I do see an awful lot of men who are in their 20s, 30s, and even 40s with erectile dysfunction. Could they have a vascular problem? And the answer is yes, they could. But more often than not, the younger men will have some psychodynamic issues. And it's all about arousal. If you think about how we respond sexually, most of us, when we're not engaged in any type of sexual activity in terms of men, are flaccid because there's no message coming from the brain to tell the blood vessels in the penis to dilate. But then, whatever the arousal signal is, that's sent down via nerves to the penis. Those nerves cause a release of chemical that cause those tiny little 1 millimeter blood vessels to dilate. So basically, we're turning a straw into a hose. Blood comes rushing in and fills the tank of the penis. And if indeed the tissues within the penis are healthy, as the blood expands and creates pressure within the penis, that traps blood vessels, traps the blood within the penis so that we maintain our rigidity until orgasm and ejaculation. So that's kind of the simple understanding of how erections occur. Arousal, neurovascular event, and of course that has to happen in the proper social, psychological environment to foster that type of process. What do we do with that? Well, if we have men who have erectile dysfunction, I think you all know that there are a variety of options out there. For men who have a primary psychological issue, we send them for sex therapy with a lot of success in men who can appreciate the relationship with a sex therapist that can benefit them enormously. For those who have more of a vascular or a neurological cause to their erectile dysfunction, first-line therapy is using medications like Viagra or Cialis. There's some other ones that are less commonly used, but they're available. They have about 65% success rate, a very low rate of adverse side effects. And a lot of people I see still think that, can't take Viagra or Cialis because it might do something bad to my heart. No, the problem is that maybe your heart is not good and cannot tolerate the exercise, albeit not very much, the exercise of sexual activity. So if your heart is good and you can walk up a couple flights of stairs without trouble, you are certainly a candidate for medicines like Viagra and Cialis with, again, a fairly high rate of success. When Viagra or Cialis don't work, we can go on to other types of treatments like injection therapy that began back in the 1980s. There are vacuum devices, very simple devices, a little plastic tube that's placed over the penis, and you vacuum the blood up into the penis and then trap it there with a rubber band. Fairly non-invasive and simple, but a lot of men don't like it because it's somewhat cumbersome and unnatural. In fact, probably less than 1% of my patients will use a vacuum device. And for the man who's failing all those options, the next step is what's called a penile prosthesis, an implant, an outpatient surgical procedure. I've done over 4,000 of them for men from all over the country. And probably the happiest campers I have in my practice are men with an implant because they know they can get erect when they want to, whenever they want to, as frequently as they want to, without restriction. It is a fairly simple outpatient 1 hour operation with a high degree of not only patient satisfaction, but I've also done surveys on the female patient partners of those of my male patients, showing a high degree of satisfaction for them, not only in terms of their own sexual satisfaction, but also in terms of their appreciation of how natural the penile prosthesis may look to them when it's flaccid, when it's hard, and most importantly, during sexual activity. So the implant is certainly something that is reasonable to consider and most often covered by insurance. There are some newer things which are out there that people, you might hear about it on the radio, shockwave treatment, the so-called P-shot. These are to some degree unproven. Certainly the P-shot or doing stem cell injections, but shockwaves do have some evidence of benefit in the medical literature, primarily in younger men who respond to pills like Viagra and Cialis, but don't want to take them. And so shockwaves can be used, but unfortunately not usually covered by insurance. And so that may be a few $1,000s out of pocket to see if that works. For more advanced erectile dysfunction, it's not particularly effective. And so discussing this kind of stuff with your physician, should you be interested in pursuing that kind of stuff, should be evaluated in terms of what makes sense for you. So let's move on to the next topic, which would be low testosterone. Now, low testosterone is actually also quite common. Men sort of peak out with their testosterone probably in their early to mid 30s. And then about 1% drop per year, assuming that you're a normal, healthy man. Other things can accelerate that drop in testosterone, like chronic illness of any sort, congestive heart failure, COPD, diabetes, and obesity accelerate the reduction of testosterone. And taking just a pain pill, like a opioid for chronic pain, just one of those pills can drop one's testosterone down to almost non-detectable levels very quickly. So people who are on chronic pain medications will tend to have very low testosterone. And that all is important because testosterone is a critical hormone for men. I also said for women as well in terms of libido. But for men, it is known to have receptors on virtually every tissue in our body. So it affects our brain, it affects our bones, it's good for our muscles, it's good for our liver, it's good for bone marrow for making blood, and on and on. And of course, making sperm as well, and for our sexual function. As I said earlier, testosterone has a permissive effect, meaning that you need to have a certain amount of it around to have your libido and desire. If the testosterone is very low, you may feel like, geez, you got no interest in sexual activity. So we want to make sure when we see men who do complain of issues of intimacy or erectile dysfunction, that their testosterone is checked. And that's typically done sometime before 11 o'clock in the morning because those levels tend to be higher in the morning and then drift down over the course of the day. For men who are found to have low testosterone, there are a variety of treatment options currently available. There are now a couple different pills that can be taken safely. They can be expensive and sometimes insurance can be an issue, but that can be pursued. There's the old-fashioned shots, which are still quite popular in my practice. I've switched a lot of my men to just using what we call a subcutaneous diabetic type needle injection, which they give themselves weekly, and it tends to have the lowest rate of side effects and very high satisfaction. There are gels that can be rubbed on, and there are pellets that can be injected into the buttocks that can last quite a while and then need to be maybe replaced every 4 to 6 months. So there's a lot of different options for testosterone. And then the goal with testosterone replacement is to take care of some of the symptoms. And those symptoms would include maybe low libido, potentially improving erectile function, energy. A lot of men with low testosterone just have really no joie de vivre, no energy to do things. They become couch potatoes and gain weight and look depressed. And in fact, they are. But by replacing testosterone, we can see improvement of a lot of those symptoms. Long-term low testosterone is certainly an issue because it can have direct effects upon more accelerated loss of muscle and bone. And of course, women tend to have very rapid potential loss of bone mineral density once they go through menopause. For men, because it's a slower process, it tends to happen later, but it still can happen in men as it does in women in terms of that bone density issue and therefore a higher risk of fracture. So testosterone is a very important, critical hormone for a man's health. Um, there are, with any therapy, potential risks of taking testosterone. What we've learned, though, over the last decade or less, is that testosterone does not, as previously thought, does not cause prostate cancer. It can wake up a prostate cancer, but it doesn't cause it. Um, it also does not cause cardiovascular disease. There were a couple studies that came out in 2013, 2014, created a whole bunch of anxiety and distress in the medical community that testosterone was causing early cardiac events, heart attacks, strokes, things of that sort. No, that's not the case either. Again, most of the men who experienced those problems had underlying issues that predisposed them to having a heart attack or stroke. And the testosterone was just putting them back into the normal range so they could function otherwise, but did not cause it. The real primary issue with testosterone replacement is that it can stir up your bone marrow to make too many red blood cells. And so that has to be monitored. And typically every 6 months, I get a blood test um, uh, of my patients to make sure that their blood counts are satisfactory and that their prostate is functioning properly and that testosterone's in the normal range. So those are the things that I wanted to share with you today. Um, that ED common, but very treatable, and maybe preventable with monitoring your health. And good things to do for your health is exercise and diet, getting good rest. And of course, the other is low testosterone, which is also common, but again, a treatable issue should you find it. Thanks very much, and I appreciate the opportunity to speak with you all. Franco, back to you.
Thank you, Dr. Levine. This was super informative, and just while we have you here, again, this is we're doing things a little bit different for those joining us live on YouTube and also here in the chat via Zoom. If you have any questions for Dr. Levine, we're just going to open it up for a couple minutes to answer any questions. I know I found this chat very informative. Interesting to find out about the physical workings of men's sexual health, but also had no idea, just simple things, it's not simple, but something as simple as one might think smoking is and the impact that it could have on your sexual health. And obviously I knew about the cardiovascular implications, but that in men that could be such an early detection of cardiovascular disease. And obviously it could lead to ED as well. So super enlightening. If we have any callers that are with us and have any questions for Dr. Levine, please hit *6 to unmute yourself. And also we'll be taking questions from YouTube. I know one that did come in on YouTube is all the things that you mentioned, such as treatments, therapies, medication, and possible surgeries, should that be the case for the candidate. Are those, how does that impact a person, and is that usually covered by medical insurance is one concern?
Well, for the most part, the drugs, such as the Viagra Cialis group of drugs, thankfully now are generic, so they're much less expensive than they used to be, and pretty readily obtainable. Um, and it varies from insurance to insurance whether it will be covered. Commercial insurances will cover it very well. Government-sponsored insurance like Medicare, Medicaid does not tend to cover those pills or much of the other treatments for erectile dysfunction other than placement of a peanut prosthesis remarkably, so that even though they won't cover the vacuum device or pills, they will cover the surgery if there's a clear indication to do that. And again, a trial of medications would be one way to determine whether you're a candidate for the implant, because if you're not responding or you're responding badly, you have side effects, the implant would be another option. The goal is to just make you normal man, not to make you necessarily Superman. It'd be nice to be Superman, but be back to normal how you were functioning so that you knew that, when you approached a sexual situation that you were, ready to go. And of course, that builds confidence. And confidence is a wonderful thing to have as you're approaching things in the bedroom to know that you can be satisfy your partner.
Thank you again. So just to recap for medications, if your insurance does not cover, now that some of the more popular medications for ED have been available to be more generic, the pricing can be available sometimes in a low rate or discounted if you look for those.
Right. Always a good idea to, if you can, is to try those good RX, those discount cards, because I've had people come in and say that they paid 20 cents a pill for, Viagra or Cialis these days. It might be more, but it can be as cheap as 20 cents to a dollar, whereas it used to be $20 or more per pill.
And while we have you, Dr. Line, a question did come in from YouTube. What kind of testing is needed to determine someone's testosterone level, both in men and women, if that is a situation?
Blood test. It's simple morning blood test, typically done before 11 o'clock in the morning. What I do is I get a free and total testosterone. That's a way of looking at it in the blood. So free and total testosterone. We also look at the pituitary hormones that tell the testicle to make testosterone. LH is one of those. We look at prolactin, another pituitary hormone. We can look at estradiol, that's the female hormone, because some men, particularly obese men, may have too high of an estradiol level because testosterone is metabolized, is converted to estradiol, particularly in fatty tissue. And if a man has too high of an estradiol, that can be an adverse problem. So we want to switch that back to testosterone, which there are medicines to do that as well. So a free and total testosterone, LH, prolactin, estradiol, and is the sort of standard battery of tests that we get, very readily available, and again, just obtained in the morning.
And your sexual health healthcare provider would know that those are the traditional tests that they would just have to say, I just want to get myself tested for
Yeah,
testosterone level.
correct. Yeah, they ought to
Great.
know that. They're worth their salt. They should know.
Awesome. And another question is, what are some ways males can identify ED versus stress related ED
Well,
dysfunction?
that's a real good one, and I'd say that the number one cause of low testosterone that I see in young men who come to me who clearly have actually a measured low testosterone and have the symptoms of low testosterone, low libido, low energy, easy fatigability. Probably the number one most common cause is stress. So who doesn't have it? But it's kind of like how our body deals with it. And one of the things is that we somatize, we put it internally, and that can shut down our testosterone. As far as the ED aspect, stress can also have an adverse effect there because, again, as I used to say, when a man has difficulty having a sexual encounter the first time, there's fear. Uh, If it happens again and again, that becomes panic. And panic activates different processes in the brain, which actually interferes with that blood vessel relaxation process that we were talking about. It actually causes those blood vessels to clamp down. Um, and can certainly then block the ability to have a satisfactory erection. So, if stress is determined to be the cause, again, a good reason to see a therapist to try to get the baggage out and become more functional, so to speak.
Great. Do we have time for one more question from you?
Yes.
Terrific. Someone from our YouTube is asking, is there a way to use the drugs such as Cialis and Viagra? Any considerations using these, such as diet, exercise, etc.?
I'm not sure.
What
What's the question?
is there a proper way to use these drugs such as Cialis
Oh,
and Viagra? Any other considerations using these, such as diet, exercise, etc.?
well, I mean, if you're overweight, then we want to get your weight down. There's no doubt that that contributes to, vascular, again, accelerating vascular disease throughout your body and maybe at first in the penis. If you're a smoker, if you have high blood pressure, all those things will accelerate vascular injury. That naturally happens with aging, but now we're putting the foot on the accelerator and accelerating that process, making it more likely to happen. So anytime a doctor suggests a certain therapy, things that the patient can do to enhance their overall health is, take your medicines as you're supposed to. Get some exercise every day. You don't have to have a huge sweat. Go out and take a nice vigorous walk. Just cracking a sweat means that you're getting your heart rate up, and that's good for your vascular health. And try to eat better, avoiding certain types of fatty foods and fried foods, things of that sort. Anything that you get at the fast food place is probably not going to be good for you. It might taste good, but it's not going to be good for you in the long run. So make it a treat rather than a habit. Now, as far as the pills go, they should be taken typically an hour or two before anticipated sexual activity, so that you have it up and running in your bloodstream. Best not to have a tummy full of food because that will delay emptying of the stomach, and so the drug doesn't get into the bloodstream. So having less food in the stomach is good. If you think, hey, we're going to go out to dinner and maybe make whoopee after dinner, it might be a good idea to take the medicine before dinner so that you have it up and running in the bloodstream, but you have an opportunity for it to get into your bloodstream, and then later on in the evening. Now, alcohol is a concern here. Having a drink or two here and there might make a person more relaxed and comfortable, and may make it easier for them if they're anxious to perform sexually. So it can have a relaxing effect, and that can be beneficial to a point. But if you're drinking too much, and what that is, it varies from patient to patient. But certainly, if you're drinking too much and you're getting drunk, well, then that has a central depressing effect upon the brain, and so that arousal signal is not being conducted down to where it belongs, and then things won't function well at all. So, regulating alcohol is also very important to be able to, function optimally.
Thank you so much. As always, very fascinating to have a conversation with you, Dr. Levine. We could be here for days and or hours and days. And I'm sure the questions will continue to roll. Being cognizant of your time for today, I just want to say thank you again for joining us.
My pleasure.
And we will forward anything else that we get in our way. But thank you again for today and moving on for today. So thank you for joining us.
I appreciate it. I want to thank Hannah and you, Franco, for putting together a good program. Take care,
Thank you
all.
again. Thank
Bye
you.
bye.
And now, without any further ado, I'd like to invite Dawn to join us in sharing her lecture for today.
Thank you so much. I really appreciate the opportunity to be with you all today, both on Zoom, on YouTube, and those who watch this later. I have a slide deck because I'm a visual thinker. So know that this is something, you can come back to and review the recording, or those of you who get access to the slides. I'm going to fly through a few things just as sort of disclaimers and context, and then we'll get into the good stuff. I really learned a lot from Dr. Levine as well, so I'll try to weave some of my thoughts on that in as well. My name is Dawn Ravine. My master's is in public health, so my main disclaimer is that I'm not a doctor, but I do have 25 years in the classroom, both with young people, teens, as well as with parent caregiver spaces, and adult professional development spaces focused on sexuality, gender, and health. Um, Couple disclaimers. This is my own content, so I'm not here today representing my employer. Um, I have some biases and limitations. Like I said, I'm not a doctor, and I am 45, so I'm not quite in the age group that we're speaking focused about. So I just want to be clear, you are the expert on you. So my viewers today, please take what works for you and leave what doesn't. Hopefully I will leave you with some thoughts and conversations that you might go ahead and have with your own health provider, as this is not medical advice. Please expect and accept non-closure. There's a lot of possible avenues that we could go with a conversation on sex and intimacy. So you can kind of think of my slides today as a menu of things we could talk about more in Q&A, or that you could follow up and gather more information about. And just a note on inclusive language. Not all women have a uterus. Not all people with a uterus are women. So when I'm talking about social impacts on our relationships and our sexual lives, I'll talk in terms of gender. And when I'm talking about body parts, body functions, health conditions, I'll use that medically specific language. And you all can just be the experts on yourself and what works best for you. My team, for context, I currently manage a team of 6 sexual health educators. We work with a variety of age groups, like I mentioned, and also do LGBTQ inclusion trainings, and provide some social spaces for youth. We serve over 5,000 youth and 1,000 adults each year. So I get the benefit of just constantly learning and hearing from people across Chicago. A little bit on my home hat. I'm a parent to a 15 and an 18-year-old, so I have that lens as well. And for those of you just listening in, to give some image descriptions, you'll see my 18-year-old in her amazing power chair that helps her get around. She is medically complex. And my 15-year-old, who is a creative and amazing human being and also autistic. And so I do have some images on my screen just reflecting that affirmation of neurodiversity and disability. And so I think that always informs my work as well. I am, as I mentioned, 45, so I'm also personally in the midst of getting acquainted with being a caregiver, having these, roles of support in my work life, and experiencing perimenopause. So I'm going to talk a little bit about the impacts of perimenopause and menopause today. I always, before I talk about bodies, like to start with some conversation on consent. A culture of consent and equity and bodily autonomy is good for our sex lives, it's good for our relationships. And I have this beautiful quote from Adrienne Maree Brown: "Your no makes the way for your yes. Boundaries create the container within which your yes is authentic. Being able to say no makes yes a choice." So when I was asked to talk about, women and aging and sex and intimacy, the very first thing that came to my mind is how often we are asked to put other people's needs above our own. And for many of us, that's an incredible opportunity. We care for our families, we care for our colleagues, we care for our communities, and what an incredible thing to get to do. But that also is a great deal of pressure and stress, and sometimes makes it really difficult to be in touch with ourselves, our bodies, our sexual needs. And so that sort of culture of consent, that idea that as we set boundaries, as we make space for ourselves, we are able to more authentically say yes to the things we genuinely want. And that includes our sexual needs. I always take a reproductive justice framework. This is a framework that comes from Black women activists in the 1990s who are working around reproductive health, and really just wanting to have an understanding that our physical health is always informed by the social and the structural context that we are living in. So if we have access to what we need, both for our physical health and our support, we are able to be, kind of healthier both for ourselves and our communities. And I will mention intersectionality just a bit in my talk, so I just have this context as well. If that is information that you want more on, you can look into the Center for Intersectional Justice and the work of Kimberly Crenshaw, who is a legal scholar. All right, so here we go. Now we're diving in. What impacts pleasure and relationships as we age, specifically as we think about women as a social group? So I want to start with the physical. Many people with these body parts of a vagina, vulva, and uterus experience a lot of different health needs and chronic health conditions throughout our lives. I'm thinking of things like fibroids, PCOS, endometriosis, various reproductive cancers and precancers, surgeries, hormone therapies, things like miscarriages and birth experiences. Um, I'm also thinking of things like pelvic floor dysfunction. And this is really, as we age, something that, many of us experience. Those untreated pregnancy and birth injuries, often from decades ago, really come into play at this stage of our lives, and can bring about issues like incontinence, prolapse, right? And these are obviously things that make sexual intimacy more challenging. Um, Perimenopause and menopause can bring about vulvar-vaginal symptoms, things like vaginal dryness, things like vulva pain, difficulty with insertion into anything into the vagina, dryness, irritation, right? Difficulty with arousal and orgasm. So those can be some of the physical challenges that may come up. There are also social emotional challenges. So I've mentioned some of these already, but just to point them out further, um, the social and emotional impacts the physical, right? So if we have increased care responsibilities, maybe we have our own aging parents who we need to care for. Maybe we have, young adult children who still need our support. Maybe we have friends and family or a partner that needs a lot of care right now. Many of us experiencing loss and grief, and this might include things like divorce or death of a partner or spouse, um, ending of our work life in different ways, or change of our work experience, the experience of a change in our community or isolation, um, impacts of our changing body on our social emotional well-being, right? Those body image pieces, right? That confidence. I think Dr. Levine spoke about it as well, but that confidence in our body really can compound into either a very positive experience or a very negative experience. So that relationship with our body is very key. And then I always want to point out, right, I brought up the concept of reproductive justice and intersectionality. I think we have to acknowledge that there's the pieces we can control as individuals, and there's the pieces that we have to acknowledge are impacting us that might not be in our control. So that sort of disproportionate care work across the lifespan for many women. Um, the real disparities in research, many of the health conditions I've mentioned so far get far less funding for research. We see far less funding for the research on things like perimenopause and menopause than we do on things like erectile dysfunction. So there's really a need, or arousal needs, for people with a vulva, people with a vagina, right? That is not researched at the same level. So those research disparities may be impacting even our conversations with our health providers. They might not have all the information they need to support us. Disproportionate rates of sexual abuse and domestic violence and sexual assault, right? That might impact us in our full life course as we're navigating health and relationships. Some of those intersectional inequities, so we think about gender combined with things like race, age, class, immigration status, sexual orientation, gender identity. And then, of course, just aging in the United States. I think, we are certainly a country without universal health care that often deprioritizes the needs of our elders, and lacks some of the models needed for interdependence as we age. Okay, so now I'm going to get to the happy stuff. How can we improve sex and pleasure and relationships as we age? And for image description, I have an image from the TV show Grace and Frankie. If you have not seen it, highly recommend. Really addresses so much about sexual response and relationships in aging in really a fun and funny way. So first recommendations are physical. I think number one is always going to be exploring your own body and pleasure in new ways. As we age, as our body changes, as our hormones change, we may need to adapt how we're interacting with our body. Having good lube and supplies, especially if you're dealing with any vulvar pain, vaginal pain, or dryness. There are stores like Early to Bed that really have a kind of feminist-centered, women-centered approach to these supplies. So if you're looking for a place to have a very thoughtful conversation, that's a recommendation that I have. Early to Bed in Andersonville, if you can make it there. Um, Recommendations, additional physical recommendations. So I mentioned kind of getting more in touch with your own body and pleasure. I think Dr. Levine got to this a little bit as well. If you can experience arousal and orgasm alone, that does give you an indication that physically everything is functioning. If you have that ability and you still struggle with arousal and orgasm with a partner, that's often a sign that there's more sort of social, kind of contextual challenges coming up, maybe communication challenges or a stress level that's impacting your ability with arousal and orgasm. If you can't experience arousal and orgasm during masturbation, that can be an indicator that there's more of a physical element, and you really might want to follow up with a health provider that's really affirming and that's knowledgeable about sexual response and aging, which is not always easy to find. Sometimes we need to shop for health providers. Some of the things your health provider might help you look into is STI testing and treatment. Sometimes people can have STIs for many years, sexually transmitted infections that did not receive treatment. Caring for your overall health. So Dr. Levine mentioned smoking cessation. So we know that smoking cessation for all bodies can really impact that sexual response cycle. Working with a gynecologist that's experienced and getting questions answered related to pleasure, arousal, and orgasm. I will say, I wish all providers brought it up, but we have to be prepared to bring it up ourselves because many of them do not. And I think many providers want to bring it up, but they are nervous that, not all people are comfortable talking about arousal and orgasm. So if it's something you want to talk about, I just want to urge you to bring it up. And I'm guessing your providers are going to be very glad you did. And then exploring treatments, things like vaginal estrogen. So even if you cannot take systemic estrogen for different reasons, vaginal estrogen has very little exposure to the full system. It's very localized, so it can really help with things like vaginal pain. Pelvic floor therapy is amazing. Highly recommend. I think it's a real misstep. There are countries where pelvic floor therapy is the standard of care post-birth for everyone, and that impacts lifelong pelvic floor health. And in this country, we don't have that. So we often seek out pelvic floor therapy when we're experiencing things like, difficulty with having, urine leakage, things like that, or any kind of pelvic pain. And then high quality lube, as I mentioned. I do also highly recommend just learning about the anatomy. If you didn't get the benefit of, very thoughtful sex education when you were younger, there is just no time like the present. I have a click link here to a website called scarleteen.com. They are intended for teenagers, but honestly, I recommend them to all my parent caregiver spaces because they have so much detailed information that's very inclusive and positive about sexual and reproductive anatomies. So this is their anatomy images. They talk all about the structure of the clitoris and the arousal cycle. And I think it's just something many of us did not get from our sex ed. And if we don't know the anatomy of our pleasure, it's much more difficult to communicate with a partner in terms of what we need. And then relational and stress, I just want to point out it's okay to ask for help. If we are stressed, if we have taken on the world, then kind of settling down and being focused on pleasure can be very challenging. So please remember to ask for help, ask for support. We encourage, the exploring and revisioning ways to have community. Finding groups. You are all part of this amazing Rush Generations group. This is really one great step, but find additional groups. If you're a survivor of domestic violence or sexual harm, finding groups related to that, finding exercise group or interest-based activity groups can really be a wonderful way to manage our stress, feel centered in ourselves, have space for ourselves, and then we may find that, things like sex and arousal come more easily. This is a note to partners. If you are partnered to someone with these body parts, anticipate their needs. There is no time like the present to take on additional housework and care work. Um, Asking questions of our partners, things like, I wonder if the division of labor in our relationship has been equal, or things like, are there chores or stressors I can help better with? I would also encourage finding time for fun and flirtation and compliments. Finding time for non-sexual touching. This is definitely for all genders. If there's so much pressure on genital-based sexual contact, if there's so much pressure on orgasm, sometimes that can be its own stressor. So finding that time for like non-sexual touching that kind of has no pressure attached can help to build connection. And then therapy is awesome. Pelvic floor therapy is awesome, but also therapy is awesome. Conflict, stress, resentment, and inequity are not sexy. Really doing our own work and coming, in our relationships really thoughtfully is a way to build that connection. Communication is key. Talking about sex, right? Maybe that hasn't been part of your life before, but now it becomes even more important as your body's changing. So being able to say things like, I like when you blank, or can we try blank? Or I used to love X, Y, and Z, but now I'm finding this other kind of touch feels better. Couples therapy, sex therapy are great options as well. And then structural recommendations, just recommending more money for research on gynecologic health, menopause, and health conditions that primarily impact women. Research and policy related to gender equity will help us in our relationships. Research and policy related to supporting survivors of violence, and policy related to funding childcare and disability care and home care. And that has to include advocacy for home care providers so that they can get a living wage and training and safe work conditions and paid time off so that we can all do better. I have some recommendations for books. It's Not Hysteria by Dr. Karen Tang is an incredible overview of gynecological health, every single possible condition you can imagine, and really up to date. It's a new book, so very up to date information on standards of care. And so you can really bring specific pieces of information right to your health provider and say, hey, I noticed there's some new opportunities related to fibroids. Can we talk about that? What Fresh Hell Is This is a really amazing and slightly comedic, but very medically accurate overview of perimenopause and menopause, and includes lots of conversation about pleasure within that context. And then finally, Esther Perel is a relationships podcaster. She has e-courses on pleasure and relationships, and I just could not recommend her work more. And I will stop there and pass it back to Franco for questions.
Don, thank you so much for that wonderful, wonderful presentation. I am going to remind folks that are joining us, we're opening our Q&A portion of this presentation with you, Don. So if you have any questions and are on the phone via Zoom, hit *6 to unmute yourself at this time and join us. And for those on YouTube, please submit your questions and we'll have the conversation. I personally want to say thank you for covering so much ground in this presentation. We appreciate it. Thank you for being so open about sharing about yourself, being so inclusive, explicitly speaking about consent and intersectionality. To me, those it hit hard. The need to talk to your provider and being your own champion about sexual health with your own health provider. What a great way to really break that down for us and to remind us, because it's such an important need to take care of our overall health. Also the need for smoking cessation, how you tie that into with Dr. Levine, and the impact that that can also have on women's sexual health. Things that I'm also learning from your talk today. And you're right, therapy is awesome in lots of ways. I'm a big component. So thank you again for all that. And I want to remind folks that this is being recorded. So specifically, if there's a resource that we talked that John spoke to directly today, whether it was that book, It's Not Hysteria, or what Fresh Hell is This, and also the podcasts and other sites that were mentioned. This will be available through our YouTube channel for you to go back into reference to, and we will also have the presentation available to anyone that asks for us to send it their way. But specifically, I wanted to pick your mind and say, why do you think there's still such a stigma around sexual health and intimacy? And do you think, in your own view, is it changing?
Oh, I really hope it is. I will say working with teens has given me such an optimistic view of the future. I think our teens do feel more comfortable talking about pleasure, talking about bodies, talking about, vulvas and clitorises and using this language. Getting education on consent is really now part of sex ed during the school day. Definitely was not when I was growing up.
Right.
So I do see that there are improvements, and I think we can take a lot of solace from that younger generation. I don't think it's changing fast enough. It is a little bit heart-wrenching when you read Dr. Karen Tang's book, which I just finished it, and I just cannot say enough good things about it. So many of these conditions, the real answer is really we don't know, and a lot of trial and error. And so we are still in a place with our bodies of having to go through sometimes years of treatment before we find answers to things like heavy menstrual bleeding or pelvic pain. And so I think things are improving, but I do think, like you said, we still have to be our own advocates because there's just not enough information.
Think you hit that, spoke so well to that, and which brings me to another point. Speaking about inequality in research, and I think you just kind of touched upon that with just having to sometimes people specifically having to suffer through trial and error or a process of elimination. How are we making headway, or how should maybe listeners or viewers approach making headway in this area? How do we ask for, you know, get our voices heard?
Yeah. Oh, that's a great question. I wish I had a magical answer. I do think conversations like this go a long way, right? You have this large audience and people have their own circles. And so I think whether it's you talking within your own family context, that can be a powerful way to just advocate and share information. Whether it's talking to our providers, whether it's maybe some of you who do have, work in government or work in public policy, there's opportunities in those spaces or work in funding for research. So I think none of us can take it on alone. I think it's going to be a collective project, right? That if we can do this work together, we can really have an impact on sexual health for all people.
Thank you so much for that answer. Very thoughtful on breaking it down for, like, as you said, for us to be able to talk to our own families all the way to more structural, systemic ways to approach this. So great. One last question before we go, this was brought up, is if you mentioned in your presentation, it's okay to not be okay, and there may be shame around it. How can someone approach, or how should someone approach this with maybe their partner or their family?
Yeah.
Any thoughts?
I think this is a collective one as well, right? Sometimes I think, especially those of us socialized as women, even when we say, I'm not okay and I need help, we don't always get the response that we need, right? We know that I don't have the stat off the top of my brain, but research shows that men on average overestimate the amount of household work they do compared to how, especially when they're partnered with women, how their female partners rate that amount of work. So there's a lot of invisible labor happening. And so I would just encourage everyone to just be aware of, start to make yourself aware of the labor that can be invisible. Who's making the doctor's appointments? Who's doing the grocery shopping? Who's doing the cleaning? Who's scheduling all the different things that have to happen throughout the day and year? Who's keeping track of whose birthday it is next, right? Calling people for the birthday party, right? There's so many little pieces of invisible labor. And so I think it's both being able to say, I'm not okay, and making sure that the people around us are prepared to hear it and step in. And I think that's a balancing act that, we're all working on together and want to work on together. I think everyone has amazing intentions, and it's just a matter of collaborating and communicating more.
Thank you again. What a great lens and what a great way to end today's lecture. And I just want to personally thank you again for joining us today and speaking with us. Moving forward, I have some reminders for folks. So again, thank you, Don, for joining us and giving us of your undivided attention and time. We truly appreciate you. So as we move, I want to let you know about current and upcoming events at Rush. Our first one's going to be Take Charge of Your Health, a 6-week workshop for people with ongoing health conditions. Learn how to build skills to gain confidence to better manage your health, lead a more active life. Over the course of 6 weeks, we discuss goal setting, nutrition, physical activity, medication, and pain management, effective communication and strategies for working with healthcare professionals. Our next workshop will be held in person at our Rush campus on Tuesdays starting April 8th through May 13th from 9:30 a.m. to 12 p.m. Next, we want to hear from you. Shulman Senior Voices aims to empower older adults to discuss what matters to them as they age. It's important to share what matters most to you with your physician and loved ones. So Shulman Senior Voices wants to hear from you. Please consider sharing your wisdom on why it's important for your healthcare team and loved ones to know your goals, wishes, and what matters most to you at aging.rush.edu/Shulman/collaborate-and-connect, or scan the QR code right now that's on the screen and record on a mobile device or smartphone. Lastly, I want to remind you all about our next lecture, colorectal cancer. Colorectal cancer, I'm sorry, mispronounced that. It will be Wednesday, March 5th, again, starting at 1 p.m. like we did today. And I just want to thank you all for joining us. And as always, you can always find more information at Rush Generations. You can call us at 1-800-757-0202 or visit us on our Facebook page, facebook.com/Rush Generations. And we look forward to seeing you in our next lecture. And as always, please stay healthy and be kind.